Vascular diseases. Vascular abnormalities cause clinical disease by two principal mechanisms: narrowing or complete obstruction of the lumen by atherosclerosis or thromboembolism respectively. Weakening of the wall leading to dilation or rupture. Normal. The basic constituents of the wall are: 1. Endothelial cells. 2. Smooth muscle cells. 3. Extracellular matrix, ECM, including elastin, collagen and glycosaminoglycans. The three concentric layers intima, media and adventitia are most clearly defined in the larger vessels, particularly arteries. Arteries consist of 1. Intima. 2. Internal elastic lamina. 3. Media. 4. External elastic lamina. 5. Adventitia. Congenital anomalies mostly are important in surgery during which an unexpected vessel can be injured. The anomalies are rarely symptomatic except in the coronary tree. Among the anomalies which are pathologically important are: arteriovenous fistula, AVF, is rare small abnormal communications between arteries and veins. Causes: developmental defects, or produced from rupture of an arterial aneurysm into adjacent vein. Trauma, penetrating injuries. Inflammatory necrosis of adjacent vessels. They may be of clinical significance because they short-circuit blood from the arterial to the venous side, causing cardiac volume overload which lead to high-output cardiac failure. They can rupture, causing hemorrhage especially in the brain. Tuberous aneurysms, a saccular congenital of unknown etiology seen in smaller arteries of the brain, especially in the circle of Willis. Although their majority occur sporadically, genetic factors may be important. Cigarette smoking and hypertension are considered as predisposing factors. Although the aneurysms are labeled as congenital, they are not present at birth but develop over time owing to the underlying defect in the media. Morphologically, they measure few millimeters up to 3 centimeters. There is lack of intimal elastic tissue and muscle fibers in the wall, which are replaced by hyalinized tissue. Rupture of the aneurysm leads to subarachnoid hemorrhage, most frequent at the 5th decade and slightly more common in female. The rupture is associated with acute increase in intracranial pressure. In 20% of cases, multiple berry aneurysms occur, this type associated with adult polycystic kidney diseases. Atheromatous plaque. Consequences of atherosclerosis. Consequences of coronary artery atherosclerosis, ischemic heart diseases, IHD. Hypertensive vascular disease. It is a multifactorial disorder defined as sustained elevation of blood pressure above 140/90ths of a millimeter of mercury. According to this criterion, about 25% of populations are regarded as hypertensives. There are two types. Essential, idiopathic, in 95% of cases. Secondary, due to some underlying cause. Renal, glomerulonephritis, renal artery stenosis and polycystic kidney diseases. Endocrine, adrenocortical, pheochromocytoma, hyper and hypothyroidism. Cardiovascular, coarctation of aorta and polyarteritis nodosa. Neurogenic, psychogenic, increase intracranial pressure. Clinical features. Atherosclerosis can begin in childhood but is typically asymptomatic for decades until it finally manifests as the following. Insidious narrowing of vascular lumens, for example gangrene of the lower leg because of stenosing atherosclerosis in the popliteal artery. Plaque rupture of superficial erosion followed by superimposed thrombus causing sudden luminal occlusion, for example ME. Vessel wall weakening followed by aneurysm formation. Providing a source of thromboembolic pathogenesis. Basically, there is alteration in the relationship between cardiac output and peripheral vascular resistance. The major factors that determine blood pressure variation are 1. Age. 2. Gender. 3. Body mass index. 4. Diet, principally sodium intake. Kidneys play an important role in blood pressure regulation through 1. Renin-angiotensin system. 2. Vasodilators, prostaglandins, nitric oxide. 3. Glomerular filtration. 4. Natriuretic factors. Essential hypertension results from an interaction between genetic and environmental factors include stress, obesity, cigarette smoking, physical inactivity and heavy consumption of salt. Morphology. There are two changes. L. Hyaline arteriosclerosis. Occur in elderly patients, particularly those with mild hypertension and diabetes. The lesion probably reflect EC injury with plasma leakage into arteriolar walls and ECM synthesis from SMCs. Microscopically there is diffuse pink hyaline thickening. 2. Hyperplastic arteriolosclerosis. Characteristic of malignant hypertension. There is concentric laminated, onion skin, thickening. Aneurysms. It is a localized dilatation of the vessel or heart wall. We have two types. True. False. Causes include atherosclerosis, congenital, trauma, infection, syphilis, inflammation. Morphologically, there are two types. 1. Saccular, 2. Fusiform, types and sites of aneurysm. Abdominal aortic aneurysm, AAA, is a localized abnormal dilation of a blood vessel. It is due to atherosclerosis, which may involve also the common iliac arteries, aortic arch and descending part of thoracic aorta. Morphology, positioned between renal arteries origin and bifurcation of aorta. It is either saccular or fusiform up to 15 cm in diameter and 25 cm in length. There is an inflammatory AAA of unknown cause. Mycotic AAA is a complicated atherosclerotic due to infection by bacteria such as Salmonella. Pathogenesis. There are two theories. Genetic defects in connective tissue component leading to dissection then to aneurysm. Recently attention was focused on altered balance of collagen degradation and synthesis mediated by local inflammatory cells. So altered collagen could provide a susceptible substrate on which atherosclerosis or hypertension or both could act to weaken the wall. Matrix metalloproteinases produced by inflammatory cells cause proteolysis of the extracellular matrix proteins. A decreased level of tissue inhibitors of metalloproteinases has been reported in aortic aneurysm. Clinical course. The condition is rare before the age of 50 years and it is more common in males. Symptoms appear in case there are rupture, potentially fatal hemorrhage related to size, obstruction of iliac, renal, mesenteric or vertebral vessels, embolism, pressure on adjacent structures, ureter, vertebra, abdominal mass. Treatment is by using stent grafts, expandable wireframe, syphilitic aneurysm, syphilitic obliterative endarteritis of the vasa vasorum of the thoracic aorta leads to aneurysm which may involve aortic annulus. Pathogenesis. Obliterative endarteritis of adventitial vasa vasorum causes patchy loss of medial elastic fibers and muscle cells followed by inflammation and scarring that leads to weakening of the wall and aneurysmal dilation. Involvement of the aortic annulus leads to aortic valve incompetence and left ventricular hypertrophy. Clinical course. There are several outcomes. Pressure on mediastinal structures, lung, airways, esophagus, recurrent laryngeal nerve, vertebrae and ribs. Heart failure. Rupture. Aortic dissection. Catastrophic illness characterized by dissection of blood between and along the laminar planes of the media, with the formation of a blood-filled channel within the aortic wall which often ruptures outward causing massive hemorrhage. Affecting two groups of patients. More than 90% occur in men of 40 to 60 years of age who are hypertensive. In younger age group with systemic or localized abnormality of connective tissue. The condition may be iatrogenic as a complication of arterial cannulation, diagnostic catheterization or cardiopulmonary bypass. Rarely may occur during pregnancy. Morphology. There is intimaltia usually within 10 cm of aortic valve, which is either transverse or oblique, L5 cm in length. Dissection extends proximally and distally. The hematoma is located between the middle and outer thirds of the wall. It often ruptures outward but sometimes into the lumen with second distal tier. The most pre-existing histologically detectable lesion in the aortic wall is cystic medial degeneration. Pathogenesis. The trigger for intimaltia and intramural aortic hemorrhage is unknown in most cases. Once the tear has occurred, increased systemic blood pressure maintains progression of the medial hematoma. Clinical course. There are two types. Type A, proximal, more common, involving either the ascending portion only or both the ascending and the descending aorta. Type B, distal, starts distal to the subclavian artery origin. Sudden excruciating chest pain radiating to the back and moving downward is the common presenting feature. Most common cause of death is rupture to pericardial, pleural or peritoneal cavity. Currently 65 to 75% of patients will survive. What is vasculitis? Vasculitis is a clinico-pathologic process characterized by inflammation and damage to blood vessels, fibrinoid necrosis, leading to compromise of the vascular lumen resulting in ischemia of the tissues supplied by the involved vessels. Vasculitis. The two most common mechanisms are 1. Microbiological infection. 2. Immune-mediated. Less common mechanisms are 1. Physical injury, radiation. 2. Chemical toxins. Pathogenesis of immune-mediated vasculitides include 1. Immune complex deposition. 2. ANCA-mediated, porcine-immune. Anti-endothelial antibody. Classification depends on 1. Size and anatomic site of the involved vessel. 2. Histology. 3. Clinical manifestation. Classification predominantly small vessel vasculitis. Primary vasculitis syndromes. Predominantly large vessel vasculitis. Giant cell vasculitis. Takayasu's arteritis. Predominantly medium vessel vasculitis. PAN. Kwasaki's disease. Predominantly small vessel vasculitis. ANCA plus VA. See ANCA plus VA. Wegener's granulomatosis. P. ANCA plus VA. Microscopic polyangiitis. Churg-Strauss syndrome. ANCA VA. Essential mixed cryoglobulinemia. Henoch-Schonine purpura. Idiopathic cutaneous vasculitis. Beachit's syndrome. Classification. Pathogenic mechanisms of vessel damage in vasculitis syndromes. Pathogenic immune complex formation and / or deposition. HSP. Hepatitis-associated PAN. Production of antineutrophilic cytoplasmic antibodies. Wegener's granulomatosis. Churg-Strauss syndrome. Microscopic polyangiitis. Pathogenic T lymphocytic responses and granuloma formation. Giant cell arteritis. Takayasu's arteritis. Wegener's granulomatosis. Churg-Strauss syndrome. ANCA role of ANCA, antineutrophilic cytoplasmic antibodies. Demonstrated by immunofluorescent study. ABS directed against proteins in cytoplasmic granules of neutrophils and monocytes. 2 types. See ANCA against proteinase 3. Wegener's granulomatosis sensitivity, 90% in active DS. Specificity -95%. P. ANCA against myeloperoxidase. MPA. Churg-Strauss syndrome. WG. ANCA. Giant cell arteritis, temporal arteritis. Granulomatous large vessel vasculitis. Older than 50 years. Headache, sinus headache. Fever, jaw or tongue claudication, and scalp tenderness. Polymyalgia rheumatica, 40 to 50%. Blindness from optic nerve ischemia, 15-20%, diplopia and ptosis. Life-threatening aortic rupture or dissection, giant cell arteritis. Nodularity, tenderness or absent pulsations of the temporal arteries and other involved vessels. ES are usually increased. Temporal artery biopsy, TAB, granulomatous inflammation of the media and adventitia, with histiocytes and mononuclear cells, giant cells, irregular fragmentation of the internal elastic lamina. Positive 60 to 80%. Contralateral TAB if first biopsy negative. Prednisone at 40 to 60 mg/d. Takayasu arteritis granulomatous large vessel vasculitis. Affects aorta, its main branches, and pulmonary A. Predominantly in young women. Headaches and dizziness. Vascular hypoperfusion, limb claudication, double vision. Glucocorticoids. Wegener granulomatosis. Granulomatous, necrotizing, small and medium vessel. Involves upper, lower airways, and kidneys. Any age, 40 to 55 years, men and women equally. Upper airways symptoms, recurrent or non-resolving sinusitis, nosebleeds, nasal crusting. Sinus pain, epistaxis, persistent otitis media, saddle nose deformity, subglottic stenosis. Single or multiple cavitating/non-cavitating nodules or diffuse alveolar hemorrhage. Wegener granulomatosis. Microscopic hematuria, proteinuria, and rapidly progressive RF. Skin rash, migratory arthritis. Ocular involvement, scleritis, corneal ulceration, mononeuritis multiplex or SNES involvement, risk of venous thrombosis, DVT, P, mechanism unclear. ANCA, 96%. Lung biopsy yield 91% of cases. Renal biopsy focal, segmental necrotizing, crescentic glomerulonephritis with few to no immune complexes, microscopic polyangiitis. Non-granulomatous necrotizing small vessel vasculitis, few or no immune deposits. More common in male, average age of onset is 50 years. Persistent cough with or without hemoptysis. Kidneys, 79%, joints, 65-72%, skin, 44-58%. Pulmonary pathology shows capillaritis. Renal histology is similar to WG. Severe disease, lung, kidney, or nerve. Churg-Strauss syndrome. Asthma, fever, hypereosinophilia, systemic vasculitis. All ages but rare in children and adolescents and occurs equally between sexes. Recurrent allergic rhinitis, difficult to treat asthma, non-resolving pneumonia/pulmonary infiltrates, or persistent eosinophilia. Peripheral eosinophilia, absolute eosinophil usually greater than 1,500. Increased ESR, SHE, and IgA level. ANCA positive 50% of cases, predominantly MPO-PANCA. Histology, eosinophilic tissue infiltrates, extravascular allergic granulomas, and small vessel necrotizing vasculitis. Polyarteritis nodosa medium vessel disease. Incidence 2.9 per million annually. Men equals women. Constitutional symptoms, height, musculoskeletal symptoms, symptoms from vasculitic involvement of nerves, GI tract, skin, heart, and non-glomerular renal vessels. Suspected immunologic disease. Biopsy specimens, necrotizing inflammation involving medium-sized or small arteries, with abundant neutrophils, fibrinoid changes, disruption of the internal elastic lamina. Angiographic changes, microaneurysms, stenosis, occlusion. Polyarteritis nodosa. Severe life-threatening disease, GI tract, heart, or SNES system, 2-MKD oral psych and glucocorticoids. Non-life or non-organ threatening, glucocorticoids alone. Plasma exchange in severe cases. 5-year survival rate with treatment 80%. Relapses are infrequent, 8-19%. Pan-like vasculitis AS. With viral inf. E.g. HBV, HCV, HIV. RX with glucocorticoids, antiviral treatment, and plasma exchange-induced remission 81%, relapse 10%. If clinical improvement, immunosuppression should be withdrawn while continuing antiviral treatment. Kawasaki's disease. Hennock SCH online purpura. Small vessel vasculitis. Predominantly affects children. Suspected drug allergy or immunologic condition. Purpura, 100%, arthritis, 82%, abdominal pain, 63%, GI bleeding, 33%, and nephritis, 40%. Complication, intussusception. Recurrence occurs in up to 40%, mostly first 3 months. Tissue BX, leukocytoclastic vasculitis with IgA deposition in blood vessel walls. Typically self-limited, thromboangiitis obliterans, Buerger disease. Segmental thrombosing, acute and chronic inflammation of medium-sized and small arteries, principally tibial and radial arteries with secondarily involvement of the adjacent veins and nerves. Starts in patients younger than 35 years in most of the cases. There is strong relationship to cigarette smoking, due to rather direct toxicity, or hypersensitivity to some tobacco products. Morphology, sharply segmental transmural acute and chronic arteritis accompanied by thrombosis. Primary Raynaud phenomenon. paroxysmal pallor or cyanosis of the digits of the hands or feet, and infrequently the tips of the nose or ears owing to cold-induced vasoconstriction of the digital arteries, precapillary arterioles and cutaneous arteriovenous shunts. Median age is 14 years. The course is benign. Secondary Raynaud phenomenon. Arterial insufficiency of the extremities caused by various conditions including SLE, systemic sclerosis, atherosclerosis or Buerger disease. Veins and lymphatics. Varicose veins. Abnormally dilated, tortuous veins produced by prolonged increased intraluminal pressure and loss of vessel wall support. The superficial veins of the legs are the main sites of involvement. People at risk are: 1. Occupations with long period of standings. 2. People older than 50 years. 3. Obese individuals. 4. Women with multiple pregnancies. 5. Familial tendency, wall weakness. Morphology: the dilated veins are tortuous, elongated and scarred, with thrombosis. Clinical course: leg edema with stasis dermatitis. No embolism. Apart from legs, varices occur also at the lower end of the esophagus and aniorectum, hemorrhoids. Thrombophlebitis and phlebothrombosis. In 90% of cases deep veins of the legs are involved. Predisposing factors are: cardiac failure, neoplasia, pregnancy, obesity, postoperative state, prolonged bed rest, genetic hypercoagulability syndromes. Clinically, pain may be elicited by pressure over affected veins. Pain on dorsiflexion, homocystine. Pulmonary embolism is a common and serious sequelae. Superior and inferior vena cava syndromes. They are secondaries to compression or invasions by tumors. Tumors of vessels. Benign tumors and tumor-like conditions. Hemangiomas, capillary, cavernous, pyogenic granuloma. Lymphangiomas, capillary, cavernous. Glomus tumor. Vascular ectasias. Reactive vascular proliferations. Intermediate-grade neoplasms. Kaposi sarcoma. Hemangioendothelioma. Malignant neoplasms. Angiosarcoma. Hemangiopericytoma. Morphological patterns of vascular tumors. Classically, benign vascular neoplasms are composed of well-formed vascular channels lined by ECs. Frankly, malignant tumors show fewer poorly developed vascular channels with solid, cellular, anaplastic endothelial proliferation. A few entities fall into an intermediate group,